Hello, I'm Renato Ambrosio from Rio de Janeiro, Brazil. I'm a refractive surgeon scientist, as I believe it's important that we first frame what is refractive surgery. Refractive surgery is not only laser vision correction, it involves phakic IOLs and refractive cataract surgery. So when I think about refractive surgery planning, I must address how to customize the best approach for each eye of each patient. And I have to understand the patient needs and the patient characteristics. So most of the characteristics that I consider are related to the corneal shape, corneal properties, and axial length. Of course, we have to think about the lens and lens dysfunction, especially on the age of 40 years old and higher, is very important when you think about how to customize the approach for putting an IOL with a phakic IOL or to exchange the natural lens for a new IOL. So we have to think about how to customize the surgery, when to approach on the cornea, if you do surgery in the cornea, if it's going to be a surface ablation, LASIK, or even SMILE or LALEX, and eventually when we go inside the eye. So my main focus is to customize, and we need information. We need multimodal data so that we can get this information consciously in most effective and most efficient way as possible. The anterior is a swept source OCT that is a multimodal OCT machine. It gives you very important data from the cornea, it gives you axial length, and of course it gives you a lot of imaging capabilities for anterior chamber OCT. It gives you interesting images about the angle, about the lens structure, and all this data should be integrated on a decision-making process so that you can apply this information for making conscious decision to most efficiently help the patient. We are always thinking about efficiency and safety for the patient. I think clinicians should understand what is precision and what is accuracy. So when we think about repeatability, we do 3-5 measurements on the same eye, and we see the standard deviation of the metrics that we get. This is the repeatability. When we think about having a standardized measurement that is the reference, the gold standard, let's say, we are talking about the accuracy of this. So we need to have both. Unfortunately, we don't have a gold standard that is like the gabaritos, but we have the ability to look at the same eye many times and see the repeatability so that we get robust and trustable metrics. So the anterior is very good on the ability to give us epithelial metrics that has high repeatability, and from the literature was one of the first things that we were really impressed on. So we have reliable data, and from this data we will have to apply how to use this data for making a clinical decision. And I really believe it's an unmet medical need to use artificial intelligence, for example, to optimize the application of this type of information for making good decisions for the patients. So I followed the work for my good friend Dan Reinstein for many years. So he was one of the first ones, maybe the first one, to apply epithelial thickness measurements in the clinical settings. And of course it's very important. I use epithelial thickness since the very beginning of its availability on the OCT. I think I received my first machine in 2013. And these applications are coming every day. I see a new application. I would say refractive screening for ectasia risk. But for example, if you have a patient that has a contact lens use on 4 or 5 days ago, if I see the epithelium that is too much colorful, let's say with irregularity, I would say this patient needs to be out of the contact lens longer. That's one of the very easy applications for us to make sure when this surface is stable enough so that we can go ahead and use this data for refractive planning. And this is very important for refractive cataract patients because eventually this is one of the most important applications. When we think about ectasia risk assessment, epithelial thickness would change accordingly to the stroma. So Reinstein was very keen on giving us how to understand that the epithelium thickens when there is a depression, it thins in a bulged area, and this is going to be proportional to the rate of change spatially and of course the amount of stroma that is changed. So based on the Reinstein law of thickness modulation, I would say that the epithelium modulates as a secondary effect for the stromal bulging. So for ectasia risk assessment, I think epithelial thickness is very important, but I would say is a secondary change. Said that, I have seen many cases, and we use the very asymmetric ectasia cases. Those are the patients that have clinical ectasia in one eye and the fellow eye with a normal topography. And I would say a topography based on the reflection of the placido disc, Scheimpflug tomography, and of course topometric data from the OCT. So Scheimpflug tomography, the posterior elevation, thickness profile would give us opportunities to evaluate the fellow eye of these very asymmetric ectasia cases to understand if there is a subclinical or early mild detection that is not yet apparent on the front surface. And we have collected hundreds of those cases using different technologies. And I see that the cases that I use the OCT for epithelial thickness, we have a lot of information and a lot of learning from this type of data. Interestingly, I don't think it's going to be one machine and one measurement that's going to give us the final answer, but truly the integration of data from multimodal devices. And I have a few, for example, a patient that comes to my mind has a mild keratoconus in one eye and a very normal topography in the fellow eye. And you have data to understand tomography, either using Scheimpflug or OCT. I would say they will get kind of equal equilibrium on the accuracy for detecting ectasia changes, ectasia-like changes in those eyes. But we need to go to biomechanics, and eventually when you see the epithelium, it starts making more changes, more information about the changes on the epithelium. So it's multimodal, it's not going to be a one device, but definitely it would add us to our integration, and AI is definitely here to help us on that. Oh, we have broken a paradigm when we talk about ectasia management. And I'm keen on talking about ectasia and keratoconus as not the same thing. You know, keratoconus is by definition a bilateral disease. We have the first consensus that was done 10 years ago. This is a paper on cornea with over 1,000 citations. And ectasia can occur in any eye, and it can be unilateral because of a mechanical trauma. Keratoconus is a bilateral disease. So what is ectasia, what is keratoconus? Sometimes it's very hard to distinguish because there are patients with bilateral ectasia and there are patients with unilateral ectasia. But when you talk about keratoconus, this is a bilateral disease but very asymmetric. So when I think about the foam frus or subclinical keratoconus, whatever you want to call, the fellow eye has some changes on biomechanics, on tomography, and epithelial thickness, which is layered tomography, will be very important for us. So when I think about early detection of keratoconus, we have to understand what is your question. Is this cornea able to afford the weakening through laser vision correction from LASIK, PRK, or SMILE? That's one situation. Or is this a patient that needs a cross-linking in terms of ectasia treatment? So one is an elective procedure that you can understand if the patient can afford the surgery in terms of safety for long-term corneal structure, and the other situation if the patient needs a therapeutic procedure. And clinicians should understand the difference, so it's very important that we understand our questions. But at the end, the epithelial thickness is going to help in both of these situations. Even when you do a surface ablation, I use the PTK mode of the excimer laser with different technologies from the perspective of doing advanced surface ablation. We can also think about how to use this type of ablation as part of the cross-linking plus procedure with the Athens modified protocols, with the Cretan protocol with just PTK, or the Tel Aviv protocol that you do a topography guided at the epithelium level, or if you do the Athens protocol with a mild PTK and some surface ablation with topo-guided approach, or even advanced approaches with wavefront or ray tracing. So all this information is going to be relevant to have the epithelial thickness data. I use it for every refractive candidate that I see. I use epithelial thickness, and the Anterion gives us a very reliable machine. My technicians love it. It's easy to handle. It's cost effective in terms of time. The information that we have is easily available for my clinical flow with my computer connected to the data source of the Anterion, so I can see that in my office. Not only the maps, I can see the metrics and the images on the OCT, and it's important that we frame that we are seeing a revolution in OCT technologies. So we have different SWAP source and spectral domain OCTs coming, and it's important that we even frame it. About 2010, if I remember well, we published an editorial that topography with a P is different than tomography with an M. Now I think we need to go beyond, because we need to layer tomography or segmental tomography for epithelial thickness metrics. And we can do that with high-frequency ultrasound, with the digital high-frequency ultrasound, and also with the OCT. And I believe some Scheimpflug images are also able to do the segmentation of the epithelium with appropriate accuracy. So it's important to understand that even beyond that, we have corneal OCTs and anterior chamber OCTs. So the resolution of the OCT data, for example, a corneal OCT, will give you more information about the corneal structure. For other OCTs, you have anterior chamber data. And I think for us, it's a very nice time to practice ophthalmology and refractive surgery and cornea, because we are able to really see and do what we call as an optical biopsy. So the integration of the data will help us, and all this information will be more and more applied from our perspective as clinicians to help the patients. Okay, so the relevance of the epithelium is unquestionable. I use it, as I mentioned, since 2013. So we need epithelial thickness. It gives us a new domain of understanding about what's going on with the patient. But the epithelium is literally part of the multimodal approach. So it's the very superficial part. Even more superficial, we have the tear film, which we cannot neglect. We also, for example, if I see a patient that has LASIK done a few years ago and he has regressed to -1, I want to understand about axial length. I want to see the lens structure, if there is any myopia that is happening because of lens changes, like index of refraction myopia on the cataract, early cataract formation. We can think about epithelium to explain us, because it can get as a thick epithelium is a regression. And then eventually a thin epithelium can be an early form of ectasia detection. So it's very important. The only ectasia case, by the way, that I produced, it was a SMILE case that happened in only one eye, the ectasia. And the fellow eye was not an ectatic eye, and the thick epithelium and that eye, the epithelial thickness, was very important for me to understand there was no ectasia in the other eye, so that I didn't need to do a cross-linking in that eye, and just optimizing the ocular surface with oral riboflavin, which I believe it does help this patient still stable in the fellow eye. And of course, the first eye, the eye that had ectasia, the epithelial thickness was very important for me to understand what was going on and eventually see the results that I had. And I wish I knew that 2 or 3 years before the ectasia was obvious at my clinical exam, because that patient had ectasia 4 years after SMILE, and eventually epithelial thickness could have helped me, along with the posterior elevation of the cornea, to have an early detection of ectasia. And maybe a clinical approach for telling the patient not to rub the eye or oral riboflavin could have changed the evolution. So it's kind of the mindset of the black box thinking that we can learn from our, I wouldn't say mistakes or failures, but learn from the suboptimal results that we had, so that we can learn from them and get information to prevent and even to do a better work for our patients. Well, I think we have still some questions to be answered on proper studies. The influence of tear film is very relevant. So one of the key questions is, for example, if I have a patient for refractive cataract surgery that has some mild form of dry eye. So the tear dysfunction has to be optimized before the measurements and of course before surgery. So I think epithelial thickness will help us to be one of the indicators when I can get the data for a refractive cataract surgery planning, for example. So all these eventual situations can help us, but I think when we consider reflective technologies like the placidodisc reflection and OCTs, which is a projection, and even Scheinflug, I think we still have some questions. What is the best resource of data? And of course, all the formulas, all the applications of using this data should be optimized based on the proper clinical applications. That's a good question. Envisioning, it's like predicting the future. I don't have a crystal ball, but I like to quote Abraham Lincoln and Peter Drucker, for example, the best way to predict the future is to create it. So we actively can help on the shaping on how to apply technology for us to help patients in the best way as possible. And in one word, it will be integration. Integration of data from the OCT, multimodal application of the OCT itself, and of course integrating with other devices for diagnostics. But I think one of the approaches that, at least in this meeting, I always get my mind open and I learn from many colleagues that I love and admire from our field. We have robotics and we have digital imaging coming very, very important. And I think OCTs are going to be key on these applications. For example, if you have a good microscope with digital imaging and 3D visualization with the OCT integrated, as I can see the connection with Bausch Lomb and Heidelberg, I would say I can envision a beautiful machine, not only to see what's going on, but eventually to measure what is going on during surgery for thickness, for curvature, for all the applications that we will be able to take the advantage of using, and our surgeries will be more efficient, safer, and at the end of the day, patient care will be definitely optimized. And that's the key for our work, to help the patient the best way as possible.